Brian Volpp. I'm a physician trained in radiation oncology. I'm the medical director of San Diego Radiosurgery. Did my undergraduate work at Princeton University and then came back west to do my medical training at Nevada and Loma Linda. And then I did my residency training at Cedars-Sinai Hospital in Los Angeles, along with Kaiser Permanente, also in Los Angeles. When I finished up my radiation training, came back here to San Diego and have been with X-Ray Medical Group for about 7 years. Stereotactic radiosurgery is a unique way of delivering radiation therapy to a precise target within the body. It's typically 3 centimeters or smaller that we like to treat with radiosurgery. It's very high dose. It minimizes the radiation to the adjacent tissues in the body. It allows us to overcome any radio resistance of tumors that renal cell cancers, for example, melanomas are typically resistant to standard doses of radiation. So radiosurgery allows us to hit those and still be very effective. It requires a very precise setup, and we have the ability to track where the tumor is using X-rays that are built into the floor of the vault, along with a cone beam CAT scanner that's built into the machine. And so in order to have an accurate, precise treatment, you need to have very good immobilization, very good accuracy, and then a way of developing and delivering a high dose of radiation therapy. We typically have outcomes that are on par with what you would see with a traditional surgery, but it's a much less invasive option. A very good option for patients that are not good candidates for surgery, either because of bleeding risk or anesthesia risk. So it's a very new cutting-edge way for us to treat these tumors that 5 years ago really were out of reach from a radiation standpoint. The Novalis TX is a linear accelerator that has a lot of bells and whistles. It basically combines a standard linear accelerator, which is this main part of the unit, along with some special upgrades. It has X-rays that are built into the floor for targeting purposes. It has a cone beam CAT scanner, which is on either side here. It allows us to target tumors that may not be well visualized with standard X-rays. It also has a robotic table that I'm sitting on over here that allows us to move the patient millimeters in 6 different directions. It has very precise ways of immobilizing the patients and delivering a precise beam of high dose radiation to a specified target, both within the head and outside of the head. It has the ability to target lesions not only using standard X-rays but also using CAT scans. So it eliminates the need of having fiducial markers placed, which is the way that we traditionally would do radiosurgery with other units. And so it gives us a lot more options in terms of how we treat patients and broadens the type of patient that can be a candidate for radiosurgery. If a patient's a candidate for radiosurgery, not only are they getting something that's much more effective than traditional radiation, but it's much more convenient. So to give an example of a lung cancer, an early stage lung cancer that might be treated 10 years ago using standard radiation at a low dose per day, patients have to come in for 5 or 10 minutes Monday through Friday for about 6 weeks. We're now able to treat those patients in typically 4 to 5 fractions. And where the old data would show us that they would only have about a 30 to 40% local control rate, radiosurgery now is giving us about a 90% control rate. And that's been published not only throughout the United States, but when we've looked at our own internal data here, we've seen control rates in excess of 90%. So when you compare radiosurgery to traditional surgical data, very comparable and obviously much less invasive. Specifically for lung cancer, you're talking about a thoracotomy where patients would have a pretty major surgery to remove a lung cancer. We're able to do that non-invasively and get it done with basically in a week. Many patients can benefit from the Novalis, but there are patients that are not ideal candidates for that, and it really depends on what their diagnosis is and what their stage is. Tumors that tend to be more systemic based or blood based are not going to be good candidates for that. Example of that would be leukemia, lymphoma, myeloma. Oftentimes are not great candidates for radiosurgery because the tumor is so disseminated. In addition, solid tumors that are more advanced in their stage 3, stage 4 tumors oftentimes are not good candidates for radiosurgery either. That being said, we are always learning about expanding the use of this machine or radiosurgical machines in general. More data is coming out in our literature. So we are now seeing more advanced patients that are being treated with radiosurgery. And so it's always best to ask your doctor and maybe have a formal consultation with a radiosurgeon that could talk to you about whether it's an appropriate modality for you.